Restrictive lung disease and OSA. So based on a recent survey that some of you took, we're going to answer the following questions. What is restrictive lung disease and how does it present on a PFT? What is OSA and how do we diagnose it? Can restrictive lung disease worsen OSA? Supportive therapies for patients with both. So restrictive lung disease is a decrease in the total volume of air that the lungs are able to hold. It is often due to a decrease in the elasticity of the lungs themselves or caused by a problem related to the expansion of the chest wall during inhalation. Do you know what PFT results would mean? Restrictive lung disease. So 81% of you said yes. 18.2% of you said no. So we will be reviewing restrictive lung disease PFT results. So TLC, total lung capacity, will be decreased less than 80% of predicted. TLC is the gold standard for diagnosis. It is reduced because the lungs cannot fully expand. Forced vital capacity, FVC, will also be decreased. FVC is the total volume of air exhaled after a deep breath. It is reduced because of the limited lung volume. Forced expiratory volume in 1 second, FEV1, decreased or normal. Since the lung volume is limited, the total volume of exhaled air is also lower, though airflow speed is not the primary issue. FEV1, FVC ratio may be normal or increased. This is key in distinguishing features from obstructive diseases. The ratio is normal because both FEV1 and FVC are reduced proportionally. Diffusing capacity, decreased in intrinsic diseases, but normal for extrinsic diseases. So DLCO measures how well gas transfers from the lungs to the blood. In intrinsic lung diseases, damage to the alveoli impairs gas exchange, causing reduced DLCO. In extrinsic diseases, the lung tissue is not directly damaged, so gas exchange can remain normal. How restrictive lung diseases are classified. So once a restrictive pattern is identified on a PFT, the DLCO helps determine if the cause is intrinsic, related to the lung tissue, or extrinsic, related to the tissue outside, issues outside the lungs. This mnemonic here, PAINT, can help you remember pleural, alveolar, interstitial, neuromuscular, thoracic cage abnormalities. These are some of the causes for restrictive lung disease. So pleural, alveolar, and interstitial are intrinsic causes, such as idiopathic pulmonary fibrosis, sarcoidosis, nonspecific interstitial pneumonias, and then neuromuscular and thoracic cage abnormalities are our extrinsic causes like hyposcoliosis, pleural effusions, muscular dystrophy, ascites, and obesity. Now we'll go over OSA. It is a sleep disorder characterized by repeated episodes of complete apnea or partial hypopnea, collapse of the upper airway causing oxygen desaturations or sleep arousals. For a diagnosis of OSA, the primary result of a sleep study is the apnea-hypopnea index, which measures the severity of breathing interruptions during sleep, and it can be categorized under mild, moderate, or severe. Some symptoms of OSA are gasping and choking during sleep, loud snoring, frequent nighttime urination, and then you may wake up with a morning headache, and during the day you may have some difficulty concentrating. During our survey, some of you were not able to answer this question correctly. All three of these options are causes of OSA. So obesity, then we have our anatomical. Obesity is the most common. Our anatomical, such as craniofacial abnormalities, which is micrognathia, retrognathia, facial elongation, mandibular hypoplasia, and then of course adenoid and tonsillar hypertrophy, and then some drugs. Can restrictive lung disease worsen OSA? Yes. Smaller lung volumes can cause tracheal tugging, which is collapsing of the airways, making OSA worse. Restrictive lung disease patients have lower oxygen reserves, and with OSA, hypoxemia can be worse. Some patients with restrictive lung disease are less likely to respond quickly to high CO2s or low O2s, which can cause apneas to last longer. Patients with restrictive lung disease and OSA are at higher risk of developing pulmonary hypertension. Some supportive therapies are managing both conditions, focusing on improving ventilation, oxygenation, and sleep quality. So we can do CPAP and BiPAP. We can do pulmonary rehabilitation, breathing exercises, give oxygen as needed, help with weight management, sleep positioning, treating underlying causes, and avoiding respiratory depressants.